has used our program Mental Health 101 to better equip young people in our state to intervene in their own life or the life of a friend during times of mental distress and crisis. So I've been with the program since 2014, and in those years, I've educated thousands of students. And the ultimate goal of the Mental Health 101 program is to prevent youth suicide. However, in our time with students, we actually don't spend a large amount of our time talking directly about suicide. Instead, we spend most of our time talking about what to do before someone reaches that point of suicidal action, before that point of suicidal crisis, how we can intervene then before we reach that crisis point. And so that's what we're going to be focusing on primarily today, which is when mental health and suicide coincide, how to address some of those underlying mental health issues to hopefully prevent that initial suicidal crisis and further suicidal action. So this is a very brief outline of the topics that we'll be covering today. I did want us to begin with the same foundational understanding of what mental health is and why it's important, especially in childhood and adolescence, as well as some basic information on prevalence and onset. We'll speak more about how mental health and suicide interconnect and other factors that affect suicidality. We'll finish by discussing how we can prevent and intervene in mental health issues, and especially intervene in times of mental distress, period. And throughout the presentation, I'll be adding in some information on the pandemic, how it has affected mental health, how it could potentially impact mental health, and how it could complicate existing mental health issues and in our intervention. And I will say I will be keeping an eye on the chat. So if you have any questions mid-presentation, I would be happy to answer those. And there'll also be a time afterwards where you'll have carte blanche and be able to ask any questions you want as well. So to start with, even though I'll be spending most of my time today talking about poor mental health, I think it's especially important to mention that mental health is so much more than when someone is struggling. And that's where we need to all start with our foundational understanding. It's something that everyone has. We work on every single day, even when we're not conscious of the process. Self-care and coping are pivotal to mental health. That's something we all work on every day. And even when someone has a mental health condition such as depression, anxiety, or any of the other hundreds of mental health conditions there are, they experience those normal and expected emotions, even when they're unpleasant. Things like sadness, anger, and grief, those are all normal and healthy parts of our mental health. And someone can be mentally healthy or unhealthy, somewhere in between, even with a mental health condition. Someone with a mental health condition also has their own complex set of coping skills. They do their own things related to self-care, and they have their own ways they engage in emotional expression. Everyone is unique in this, regardless of whether or not they have a mental health condition. So it's important to not define someone expressly by their mental health struggles. It's always person first. And it's important to talk about mental health before someone reaches that point of struggle. Whether someone is mentally healthy also depends a lot on how someone feels about their own mental health. Mental health is very individual and it looks different for each person. And this is especially important to keep in mind if a child or someone else that you're working with says they're struggling, but you don't understand why. I always say one of the worst things you can do with mental health is try to throw logic at it, to try to, X leads to Y, to try to put it in that sort of terminology. Because the most important thing is that if someone is identifying that they're struggling, you don't have to understand why. We just have to respect and honor those feelings that them saying, I am struggling. So one of my favorite definitions of mental health actually comes straight from the World Health Organization. They say that someone is mentally healthy when they achieve a state of well-being where they realize their own abilities, can cope with the normal stresses of life, can work productively, and are able to make contributions to their community. My favorite thing about this definition is that nowhere in it, and if you turn to that first definition, being healthy is not necessarily the absence of any disease, condition, or disorder. And so instead, taking that and focusing on, what can someone do to cope? Can they cope with these stressors of life, which are definitely expected? We know they're coming. Can they reach their own level of productivity and their contributions to the community? That will be different for each person. And part of becoming healthy and mentally healthy is helping ourselves and helping the people we work with figure out what that means. But our healthy is going to be different from someone else's healthy. The reason that I personally, and I think it's a good idea in general to focus on childhood and adolescence when we're thinking about mental health, is because these years are absolutely pivotal to someone's development. These are the years when someone's brain is developing, with neural connections being formed, pruned, fine-tuned. Moreover, this is when much of someone's mental health foundation is built, from the trauma that they experience to how they learn how to cope with stressors. If you've gone through an ACEs training, this is something you're very familiar with, this foundational understanding of that childhood trauma leading to future impact in how someone is acting behaviorally and how they're experiencing their life. And the developing brain, luckily, is very resilient, but it's also very susceptible to these negative influences. And so childhood and adolescence is when many of someone's negative patterns of behavior are formed. For example, there are numerous studies that show when someone uses a substance such as nicotine before a certain age, they're far more likely to become addicted than someone who uses it, who their first use is at a later age. And adolescence is when many early symptoms of mental health conditions emerge as well. And how these symptoms are addressed or not addressed basically create a foundation for someone's future in life. It can create the foundation for a resilient adult or someone who could potentially go on to have a disabling health condition, suicidal thoughts, or take later suicidal action. And just a quick plug for next week's presentation, they'll be talking about building that resilience. So I definitely encourage you to attend that session as well. So people who experience untreated mental health conditions, they're far more likely to experience some of those negative outcomes, such as dropping out of school, becoming incarcerated, which we know when someone has these, then it can set them up for problems achieving what they want in life, period. And so just a quick mention, although I'll be focusing mainly on child and adolescent mental health, a lot of what I'm talking about will also apply to adults. So not only the adults you work with in your professional role, but yourself as well. So mental health conditions are very, very common. Half of people will have a mental health diagnosis at some point in their life. 1 in 5 or 20% will experience a mental health condition in a year. And the difference is that some mental health conditions, they are temporary, while as some are more lifelong. So the severity of mental health conditions, it varies definitely by person, but most fall into what I would consider a mild or moderate expression of symptoms, with about 5% of the population having what's known as serious mental illnesses, or in children, it's known as serious emotional disturbance, so, or SED. SED is a mental, behavioral, or emotional disorder that results in serious functional impairment that substantially interferes with or limits one or more major life activities. For youth, this can include diagnoses such as autism spectrum disorder, childhood schizophrenia, conduct disorder, oppositional defiant disorder. If you work at all within the DCS arena, you're probably very familiar with children in ODD and conduct disorder diagnoses. And if you work in the school system and you're thinking about children with serious emotional disturbance, these will be your children who typically will have IEPs. Mental health issues affect children of all ages. Half of all lifetime cases of mental illness begin by age 14, and 75% will develop by age 24. And the age of onset, it varies based on the type of diagnosis. So starting with anxiety disorders, which is the most common mental health condition for children and adolescents, about a third will experience one before the age of 18. The average age of onset is 6 years old. For behavior disorders, which affect about 1 in 5 before the age of 18, that includes things like major depressive disorder, also known as simply depression, and bipolar disorder. Sorry, behavior disorders does not include depressive. Behavior disorders includes things like ADHD, oppositional defiant disorder, and conduct disorder. And then mood disorders, which include major depressive disorder and bipolar disorder. The average age of onset is 13, and the last disorder, or the later disorder we typically see, will be substance use disorder, which is 15 years old. And that that can be expected because the older a child gets, the usually more ready access they have to substances. And prevalence does increase as children get older, but mental health is definitely an issue that needs to be addressed across all ages. It's definitely worth noting as well that 40% of people with one mental health diagnosis will have another. And so the more mental health diagnoses someone has, the more that complicates our work with them and their thoughts, emotions, and behaviors that are a part of their diagnosis. So, for example, it's particularly worth noting with substance use and other behavioral health disorders that half of those with a substance use disorder will have a co-occurring mental illness, such as depression or anxiety, and vice versa. Half of those with depression, anxiety, and other conditions will also have a co-occurring substance use disorder. Another complicating factor, especially when we're thinking about children and youth, is when we look at specific diagnoses, it's not uncommon for a clinician to change their mind once they get to know a child better, or for different clinicians to disagree on the diagnosis because everyone sees a different side of a child. Or it's not uncommon for the diagnosis to change as the child gets older and their personalities and behaviors continue to develop. So it's for that reason that unless you are a clinician, I definitely suggest instead of diagnosis that you focus instead on someone's thoughts, emotions, and behaviors, the severity and level of impairment a child is experiencing. Always treat the child as their own expert. Learn from what they're telling you they're feeling instead of telling them what they're feeling. But if you are aware of a child's specific diagnosis, it can help you do additional research on the symptoms a child is experiencing to simply understand them better, or so you can tailor your approach, make specific accommodations in your work with them. Knowledge is power when it comes to mental health. So if you know a child has autism spectrum disorder, has major depressive disorder, is even diagnosed with borderline personality disorder, then it can help you understand them better so you know how to work with them better. So it's worth noting that mental health conditions are not always readily apparent. Generally, we're going to be looking for long-lasting changes in behavior. However, there are a few complications that make this more difficult. First, just because someone is doing something odd or unusual doesn't mean they have a mental health condition. That's something that's important for us to keep in mind. Remember, just because you don't understand what someone is experiencing doesn't mean we can necessarily put labels on it. For someone to be actually diagnosed with a mental health condition, there has to be some level of distress or disability in social, occupational, or other important activities, and socially deviant behavior and conflict that are primarily between the individual and society don't qualify as a mental health condition unless they're a result of a dysfunction within the individual. So for example, let's say you have a kid that likes to dress up as a vampire and likes to play vampire versus werewolf. That doesn't mean they have a mental health condition, even though you're looking at it from someone on the outside. You think that's really odd, that's really unusual. But even though I'm not a clinician, you can kind of tell the difference sometimes between that level of something you don't understand versus something that might be veering into clinical significance. So let's take that same child and let's say they actually start believing they're a vampire. They try to drink their own blood. They stop going out in the day. That would be something that would be more clinically significant, especially because it's creating a level of distress. If a child doesn't like going out in the day, that's going to impair them going to school and receiving their education. So if it's creating that level of distress, then we can start understanding that distress and then treat it appropriately. Second, expected emotional responses are not mental health conditions. A child or adolescent who experiences grief from the loss of a parent or anger at the loss of an opportunity, that doesn't mean they have a mental health condition. And this is something we all need to keep in mind as we're moving back into this school year and as we continue moving this pandemic is the past year and a half has been traumatic for all of us. I think that's something that we can all agree to and agree on to some extent. So I would say it'd be really dangerous for us to expect for children to return to their normal behaviors because especially for many, the pandemic is something we are still actively experiencing. Don't expect anyone to just move on. Again, people are their own best experts. And it's not healthy for us to expect people to return to normal when the last year and a half have been this incredibly traumatic. Further, not all children with mental health conditions will be readily and easily apparent. Some people are very skilled in masking their behaviors, and the danger with this is when we don't recognize these children, those children will ultimately end up falling through the cracks when we're, spending a majority of our time working with those children with SEDs. And then we have these group of children that are experiencing depression, anxiety, other mental health conditions, but don't necessarily appear to be. And so they don't necessarily receive the same level of intervention. And lastly, certain behaviors that are indicators of mental health conditions, they're more socially acceptable, so it can be difficult to identify these as signs of struggle. This is especially common for people with anxiety. Just a little self-disclosure, I have an anxiety diagnosis, and a lot of my own behaviors that are a result of my symptoms, those are more socially acceptable. Things like perfectionism, always being early. But underneath those, there is a level of distress. So that's important to pay attention to in children is understanding that level of distress that someone's experiencing as a result of their symptom. And although we may be able to recognize children that are clearly struggling, when we talk about this, when we talk about mental health, we really just need to approach all children in the same way, which is from a place of caring and compassion. Because when we assume children are fine because they don't outwardly appear to be struggling, it means we miss kids that are hurting. They can fall through the cracks. Their symptoms and the severity can increase, and then in the future it can lead to more intense levels of functional impairment. But by that point, they may have experienced years of untreated mental health symptoms, which makes intervention much more difficult. And the question of is, why is mental health important? It may seem like an obvious question, and yes, it's absolutely important. But I would say when we're working with children, it only has been more recently that more and more people are paying attention to the mental health of children. As I've been working in this field for a number of years, and the terminology I've heard people to refer it as is it's in vogue now. Mental health is in vogue. Because I think more and more people are realizing that mental health affects someone's daily living and quality of life. And when we're talking about the intersection of mental health and suicide, talking about mental health is so important when we're talking about suicidality because mental health conditions are one of the strongest predictors of suicidal action. An estimated 90% of people who die by suicide have mental health conditions at the time of their death, and these are determined by doing psychological autopsies. But however, according to a report by the CDC, only 50% of people who die by suicide had known mental health conditions at the times of their death. So you see that discrepancy between 54 and 90%. That means we had a big group of people that were experiencing emotional distress, and no one was aware of that distress at the time of their death. So that means if no one was aware of them, they're generally not going to be receiving treatment. And the earlier we can intervene, generally the better our outcomes are. And so if we're able to notice signs of struggle and help someone access the appropriate services earlier, we can hopefully prevent further distress and ultimately, hopefully, that suicidal action. And most of us are already aware of what to be on the lookout for when it comes to, these signs and symptoms, but it always bears repeating. Symptoms of mental health conditions, they're not occasional things. And if you notice someone exhibiting any of these signs for 2+ weeks, it's time to intervene. So generally, you're going to want to focus on changes in behavior, which can sometimes be hard to identify simply because you may not be working with a child for a period of time where you can notice that change from point A to point B, which is why communication is important to the other adults in that child's life. First, changes in eating habits. This may be eating too much or too little. With eating, also pay attention to if someone has an increasing obsession with getting healthy. Just because someone has that change in behavior that outwardly appears healthy doesn't mean the reasoning behind it is healthy. Sleep disturbances can include sleeping too much or too little, not being able to fall asleep or stay asleep, new or persistent nightmares. Someone with a mental health condition may also seem fatigued or tired. These feelings don't necessarily have to coincide with a decrease in the amount of sleep that they're getting. For example, someone may be getting 10, 11 hours of sleep at night and still wake up and be exhausted. Reports of new aches and pains. This is especially common with young children because they don't necessarily have the words to describe how their mind is feeling. But from a very early age, children are taught to say, my knee hurts or my tummy hurts. And so those are that's very accessible language for children to use when they're having mental health concerns. So if someone is saying, my tummy hurts, my head hurts, that's something to pay attention to. Especially with anxiety, physical complaints are very common, especially reports of feeling nauseous. If a child becomes more aggressive, stubborn, hostile, or prone to outbursts, pay attention to grades. Even a shift upward can indicate signs of struggle. Losing interest in activities, that's a pretty standard sign we all know to be on the lookout for. If a child has, if they're showing difficulty concentrating or focusing, if they start avoiding certain places or things, or just avoidance of other people in general. Regression to behaviors present at younger ages. For example, if a child starts, yes, and I agree, I bet a lot of the school nurses see psychosomatic symptoms in school, which is why it's important for in-school nurses to be educated on this stuff as well. But for some kids, they may start wetting the bed again or sucking their thumbs. There may be changes in physical appearance. For example, if someone stops showering or bathing, or even grooms themselves more. And of course, we also know some of that changes if someone has showing up to school and they're seeming dirty. It could not necessarily be a sign of a mental health condition. It could be a sign of neglect in the home. New or more intense uses of substances to cope. And this doesn't just include illegal substances. This can include caffeine, nicotine, or other substances, even those that have been prescribed by a doctor. Other risk-taking behaviors, isolation, restlessness, new or recurrent fears, persistent sadness, frequent crying, self-harm like cutting, burning, or if someone is frequently talking about death or dying. And it is worth noting if you are working with a child that is talking about death or dying, it's likely that they're already suicidal. So a big question I always get when I'm talking about these specific symptoms is, we're thinking specifically about adolescents and their perspective is, a lot of behaviors that adolescents are showing tend to be perceived as that adolescent angst. And to be frank, some of them are. But unfortunately, when we group some of these behaviors into that category of adolescent angst, we end up missing some kids. It doesn't do anyone any harm to kind of automatically assume a child is struggling with their mental health because if it means we can be more caring and concerning, like that's good for everyone. So, but there are 3 factors that you can point to try to tell the difference between sort of normal changes or expected changes in behavior through development versus signs of concerns. The first thing we want to look at is intensity. Do the symptoms come and go, or are they more persistent? If they're more persistent, it's more likely a sign of a mental health condition. Are they mild but chronic? Again, mental health condition. If they're so disruptive that a child doesn't want to participate in certain activities, or if they're engaging in self-harm or having suicidal thoughts, probably a mental health condition. Second, duration. Does the child's moodiness come on suddenly and is gone moments later? Followed by, it's a majority of truancy cases. But So if the moodiness comes and goes and it's gone quickly, that's probably just teen angst. If the moodiness is more chronic and lasts for longer periods of time without breaks, there's more likely something bigger happening. And domains. Mental health conditions affect a child over multiple domains of their life. It's not something that's going to just affect them in school. It's going to affect them in their home life. It's going to affect them in their social life. This is why communication is key, because we have to communicate. We have to see if these behaviors or symptoms are prevalent across every single setting a child is in, because if they're not, it could be there is one precipitating factor in that one domain, and that can help us pinpoint how we need to intervene. Unfortunately, when we're kind of looking across these three areas, intensity, duration, domains, there are a lot of us that only work with children temporarily, so we don't get to see the changes in behavior. We don't get to see what someone's mental health looked like a year ago. We're only looking at what we're seeing now when we're trying to figure out what to do with it. Automatically assume that everyone moving into the school year, children and adolescents, will be struggling with their mental health in some way. So if we approach everyone with that care and compassion, then we're going to be more likely to set ourselves up for success and have kids not fall through the crack. Being just more caring and considerate in general, it's going to benefit everyone. Before the pandemic, even before the pandemic, rates of depression, anxiety, and suicide were up in our young people. By many, it's been called a crisis, and I would have to agree. Not only are we perceiving it as a crisis, but young people also perceive it as a serious issue. In fact, according to a study by the Pew Research Center, 70% of teens see mental health as a major problem in their peers. And so if you joined last week's session with Dr. Perry, we know that the pandemic is going to have a traumatic impact, and we have already seen rates of distress rise, and we can expect to see them continue rising in the short and long term as a result of these traumatic circumstances. But looking pre-pandemic, luckily there are a few points we can look to. There's the Youth Risk Behavior Survey. So in every classroom, we know about 30% of students will meet the clinical symptoms of depression. 5 to 6 of your average classroom of 30 students have contemplated suicide. 4 to 5 have planned a suicide. 3 to 4 have attempted suicide. And 1 to 2 have made a suicide attempt that required some sort of medical intervention. And as Dr. Perry shared in last week's presentation, increasing mental distress started to be seen mid-pandemic for all groups, adults and adolescents. And there are complicated reasons as to why it was increasing. But even as obviously, last week, I think even just 1 week ago, many of us were much more optimistic about things returning to normal. But with case counts increasing, I think everyone is a little more hesitant. We may have a lot more fear and uncertainty. So I think what's going to happen is even though we're not exiting the pandemic, we can expect to see rates of mental health issues and suicide increase. And when the pandemic does eventually reach its close, if it does, as we see in other disaster and traumatic events, we can expect to see rates continue to rise. And the pandemic, it definitely did have a significant impact on the emotional and behavioral health of children and the entire family unit. Because Dr. Perry covered a lot of this in last week's presentation, I'm only going to quickly address some of the behavioral health complications of the pandemic. So during the pandemic, there were many negative circumstances that contributed to mental distress, including instability of routine, loss of jobs or income, isolation, fear of illness, loss of life. And there are a few of us that really don't know anyone who has contracted the virus. I have several people in my own life that I know, and many of us know someone whose life was in jeopardy, whether that be a family member or a coworker, and even know someone that had passed away. So these circumstances alone, even though I would consider them as short-term impacts, sort of immediate impacts of the pandemic, they're going to have long-term impacts, from the ripple effects in families to workforce shortages, because there are simply, fewer people in the world, or there are certainly some families and some people that cannot return to work especially caregivers of young children, because accessing daycare and childcare services has become much more cost prohibitive than it used to be, or there are fewer spots available. So it's going to have impacts. But there are also going to be even longer term impacts, things that were happening pre-pandemic that were exacerbated by the pandemic and are going to continue to be an issue. There have been significant increases in cost of living. The housing market, for any of you that have tried to buy a house recently, I am so sorry because I've heard it is absolutely chaos. And rent prices have gone through the roof. Many people who lost their jobs during the pandemic, they still have been unable to return to work. And if they have been able to return to work, some have returned to positions where they're making considerably less than they were, or taking positions in workplaces that are more physically demanding. So thinking about someone who's in their 50s and 60s who hasn't been able to return to their same place of employment, maybe they take a job at a grocery store. It's hard physical work on the body, having to stand for hours and hours and hours. And that can exacerbate physical health conditions, which is then in turn going to exacerbate someone's mental health. And there's simply jobs that just don't exist anymore. And then there are the long-term health outcomes of actually having coronavirus and being exposed to it. Obviously, those that are immunocompromised, myself included, we spent the last year and a half pretty much in fear of contracting the virus. Even when some people appear and are excited to return to that normalcy, that fear is still present for us. And fear is having that persistent state of fear in the body. It is very damaging to the brain and the body systems. Then there are those with what's been termed as long haul COVID. Those people with persistent and intrusive symptoms that lead to continued impairment. One such symptom that has gotten a lot of, yes, I agree, that fear is back. But one such symptom that is present in many with long haul COVID is tinnitus, and that's gotten a lot of attention lately. Basically, tinnitus is commonly described as a ringing in the ears. And according to the International Journal of Audiology, almost 15% of people infected with COVID-19 experience tinnitus. And another study said that 40% of those with tinnitus that pre-existed their COVID diagnosis reported an increasing severity of their symptoms post-COVID diagnosis. And this is noteworthy because a number of studies link tinnitus to increased suicidal ideation. In fact, there was one high-profile suicide, I believe the CEO of Texas Roadhouse, who what was reported by his family were those long-haul COVID symptoms that decreased his quality of life and ultimately led to his suicidal ideation. And even though that is, one case study, there are studies that back that up, with one study reporting that 1 in 5 people who have tinnitus report suicidal ideation, and another study finding that 9% of women and 5.5% of men with severe tinnitus actually attempt to take their own lives, which is higher than the percentage of the general population that is eventually going to attempt to take their own lives. Beyond this specific symptom of tinnitus, when someone has a chronic health condition, they're also more likely to have a mental health condition. There are numerous studies that link heart disease and cancer and other health conditions to depression and other mental health condition. And a recent diagnosis of a serious medical condition can also increase someone's risk for suicide. And lastly, there has been a growing body of research that suggests that those who had the COVID-19 virus are more likely to have behavioral health impacts. So a retrospective study published in Lancet earlier this year saw that anywhere to 1/3 to 2/3 of patients had a neurological or psychiatric diagnosis in the 6 months following their COVID-19 diagnosis, with a percentage of those people, that's their first time receiving that diagnosis. And so more and more people are finding, and through more and more studies, we're finding that someone actually having COVID-19 affects the volume and functioning of someone's brain. And so not only are those people having new neurological or psychiatric conditions, those with pre-existing conditions are seeing an increasing severity in their symptoms. And what this says to me is just that the pandemic, again, it was traumatic. We are going to see short and long-term effects that are going to impact everyone's mental health, from the emergence of new mental health conditions to the increasing severity of pre-existing conditions. And what this all ultimately means is that our community's risk of suicide is going to increase. And further, with the increasing mental health needs in our community, which I'll show in a little bit how we are seeing those increase, there is going to be greater need to access mental health services. And for those who have tried to access mental health services pre and during pandemic, you know that the behavioral health system is already overburdened. People are experiencing long wait times. More and more providers, especially those in private practice, aren't billing to insurance anymore, which then makes accessing mental health services more inaccessible for a number of people because we can't afford, the $100 an hour rate, if not more. So as we see mental health needs increase, it could mean making access and care even more difficult. And when someone has difficulty accessing care, anything basically that creates a barrier to care creates an obstacle for someone seeking help. It's a point where someone can just give up and, stay with the hopelessness that things are not going to get better. So generally, the sooner someone can get help, the more positive outcomes are going to be. Another thing that's been assessed during the pandemic is suicidality and COVID. So the CDC, luckily, they have been assessing suicidal ideation basically since the pandemic began. So at the beginning, or sort of mid-pandemic, in August of 2020, 11% of their respondents reported being suicidal in the past 30 days. However, about a quarter of those people that were reporting being suicidal were ages 18 to 24, and persons that were Hispanic and Black reported higher rates of suicidal ideation than white respondents. Rates of ideation were also higher for employed individuals, not unemployed individuals, essential workers, and unpaid caregivers in that August 2020 report. In the report released in July of this year, so just about a month ago, 8.4% of the respondents through the CDC study reported suicidal ideation. And although the number of respondents reporting suicidal ideation decreased, the age group most at risk was still, it continued to be young people, with highest rates of ideation being reported for persons at or under the age of 29. And other groups that showed higher rates of suicidal ideation were transgender or non-binary person of all ages and those who identified as multiple races. Mental Health America also has a free screening program, and it has created a giant body of data that we can look to see how the pandemic has affected the mental health of our communities. The great thing about these free screening programs is it is very low barrier. Someone just needs to have internet access to be able to access these screenings. And so from 2019 to 2020, Mental Health America saw a 20% increase in their mental health screenings, meaning more and more people were concerned about their mental health, with 2.6 million screenings being taken in 2020. The most commonly taken mental health screenings were anxiety and depression, with the number of anxiety screenings increasing 234% from 2019 and depression screenings increasing 185%. Suicidality that was reported through these screenings did increase somewhat, with a 6% increase from 2019 to 2020. And specifically, because I have access to the Tennessee state level data for these screenings, for the depression screenings, which is the screening that assesses suicidality, those who were acutely suicidal, meaning they were suicidal more than half of days, were more likely to be younger, have lower income, and basically not be white. And so that is the population that showed as the most suicidal for Tennessee. Moving on to essence alerts, those are another pulse point we can use to assess the mental health of our community during the pandemic. And in 2020, of the 95 counties in Tennessee, 78 received an essence alert. And essence alerts are basically an alert that gets sent anytime there is a higher than number of visits to emergency rooms by persons under the age of 24 for suicide-related reasons, such as suicide attempts, intentional self-harm, or suicidal thoughts or feelings. So we saw the number of essence alerts rise in 2020, but there is a caveat with this data set, and that because it is relatively new, many hospitals are still signing on, so it could appear to artificially inflate those number of alerts. And in 2020, mobile crisis calls and face-to-face assessments were actually down with a decrease in over 8,000 of crisis calls, and a decrease in 8,000 in mobile crisis face-to-face assessments, and a decrease of over 3,000 crisis calls. From all reports I've received from community providers, there was not a notable increase in service utilization during the pandemic. More people weren't wanting to start receiving services despite us knowing that the mental health needs were increasing. So why was this happening? First, when the pandemic hit, people actually began talking about mental health. We were all struggling with our mental health in some way. So there was some level of normalization. People were overworked, especially those essential workers. People were more isolated. Many people were laid off. I think that is possible, Mona, that mobile crisis numbers are down. I think providers, they did do pretty good shifting to virtual options, but I think there was some delay. And I think those numbers could be down also too because of a number of reasons, which I'll talk about right now. So while there was some normalization of mental health, at least at the beginning, I think people felt more supported by their support network because more and more people were talking about mental health. So they felt like they could go to their support network and talk about the fact that they've been feeling lonely and isolated. And I think people were more actively working on their coping and self-care. But two, there was a lot of confusion about the mental health services still being provided. Some providers did close temporarily, others switched to virtual offerings. People needing help may not have known that a provider was open or taking virtual appointments. And simply in the state of Tennessee, we know that a big number of our population doesn't have reliable internet access. So how are we supposed to serve them virtually when they don't have that internet access? So they may not have even known the services that were available or been able to access them. So I know a lot of mobile crisis assessments were being done virtually instead of face-to-face. And Heather, I am also curious to see how these numbers change as we kind of are moving into a different phase of the pandemic. Additional safety protocols were also instituted at a majority of treatment centers, from requiring, negative COVID tests pre-admission. And so people may not have entered treatment or wanted to enter treatment because they didn't want to be exposed to others, therefore, increasing their risk of exposure to COVID. And there may have been people that didn't want to enter a treatment program because they didn't want to go through the headache of being tested for COVID and having to have a negative test. And so a lot of people, I think, sat with their symptoms instead of moving forward because they didn't want to have to cross that additional sort of barrier to get into treatment. So basically what this all ends up translating to is we saw an increased mental health need. More people were struggling, but not as many people were accessing preventative services as they needed. And we know that delaying treatment is never a good idea, whether it's a physical health condition or mental health condition, because when we delay the treatment, it generally means the condition is not only going to get harder to treat, but the severity of symptoms can increase and cause more impairment in our day-to-day life. And when someone has this treatment delay and increasing severity of symptoms, ultimately this could lead to suicidal ideation. We don't know if there has been an increase in suicide deaths in 2020. I live in Knoxville, and last year there were a lot of anecdotal reports about suicide being on the rise. But the simple fact is we don't know this information, and we won't know the number who have died by suicide until around either later in this year or into 2022, because there is a delay in that report of information. But we do have access to historical data. At the top of this slide, you'll see national data, and at the bottom, you'll see Tennessee data. So in our state, according to historical data, one person dies by suicide every 8 hours. We are ranked 22nd for all of the states, with first being the highest, meaning that they've got the lowest suicide rate. So we're definitely not the worst state, but we're not the best. And looking at this data and future data, something else everyone needs to be aware of is there is a law in Tennessee that was passed in 2017 that allows family members to dispute the medical examiner's determination of death as a suicide. I spent a lot of time looking to how these numbers have been impacted by that law and wasn't able to find any information, but at this time in Tennessee, family members can dispute the ME's determination of death as a suicide. So mental health conditions, specifically untreated or poorly treated mental health conditions, are a risk factor for suicidal ideation and action. But what exactly is suicide? You know, it seems pretty straightforward, but I think it bears repeating and understanding the definition is that suicide is death caused by injuring oneself with the intent to die. And what we need to pay attention to when we're thinking about suicide is that word of intent. Is someone intention to die? And there are two behaviors that are commonly considered as suicidal action by others, specifically self-harm and drug use, because not only are they ways by which people take their own lives, but someone may be using them to cope and accidentally die. Most of the time, when people, however, are turning to self-harm or drug use or substance use, it's not necessarily an indication of suicidal ideation. It's more of an indication of mental health struggles, and it's a form of coping. Someone can be suicidal and use self-harm and drug use as a form of coping, though, as well. So it just muddies the water and starts getting really complicated. So even though we want to focus on someone's intention and trying to understand them, we still need to take self-harm and drug use as serious signs of someone's level of mental functioning, because there is evidence that even if someone is using these things as a way of coping, it increases their suicidal risk. There is evidence that if someone is self-harming, they are more likely to act on any suicidal thoughts they're having because it decreases their impulse control. And we know with drug and alcohol use, it's going to decrease someone's inhibition as well. But suicide is rarely as straightforward as it seems. At face value, especially for those of us that have never experienced our own sort of suicidal crisis, what it generally looks like is that someone decides to take their life and then they do it. And suicide definitely seems like an impulsive act, but most of the time there are underlying things that compromise someone's mental health foundation. But suicide itself is a very impulsive act in that 30% of suicidal crises last under an hour. And for a majority of attempters, the time between deciding when to act on it and acting on it was 10 minutes or less. So most people have those underlying issues, but there can be reasons why they reach that point of crisis, that point of hopelessness that gets them to that tipping point where they're thinking of taking that action. Because for most people who die by suicide, they do have some underlying pathology, stressor, or trauma that creates an unstable foundation for their mental health. It can include someone's existing mental health condition, like we've talked about, but also family discord, if someone has a family history of suicide, previous suicide attempts, or being a member of a high-risk population. Specifically, the suicide rates for gay and lesbian youth are 3 times higher than their heterosexual peers, and an estimated 50% of transgender persons attempt suicide in their lifetime. And this isn't necessarily because of someone's sexual orientation or gender identity. It has more to do with the unsupportive environment around them. Another high-risk group are Native communities, who are 2 to 4 times more likely to die by suicide, and suicide is the 8th leading cause of death for American Indians and Alaska Natives across all ages. Some more risk factors include when someone is socially isolated or doesn't have a supportive social network, experiences a tipping point, such as a diagnosis of a physical illness or sudden loss, whether that be the loss of someone's life that's close to them, but also financial loss, social or relationship loss. And finally, someone who has easy access to methods of suicidal action, such as firearms, their risk of suicide increases. Tipping points are precipitating events that can trigger an acute suicidal crisis. Someone may have already been in mental distress or having suicidal thoughts for some time with no intent to act on them, but when this tipping point occurs, it can trigger a suicidal crisis. An example of someone who experienced a tipping point and then was fueled to suicidal action is someone like Robin Williams, who for years and years had maintained his mental health condition, but upon diagnosis of his chronic health condition, he eventually took his own life. So in one study, 70% of people who attempted suicide had experienced a tipping point event prior to that action. But a person's path to suicide rarely comes out of nowhere. When we're looking at what's on the slide, from along these points, all of these points to me are points for intervention. And that's why it's especially important to pay attention to the children and adolescents and the people in our life, period, to look for these points of intervention. Very rarely does suicide come out of nowhere. People really just don't wake up one day and just decide to take their life. For a majority of people who die by suicide, there is something underlying. So specifically, when we're thinking about mental health conditions as the sort of unstable foundation for someone who attempts to take their own life, mental health conditions themselves are caused by complex circumstances. Sometimes there's just faulty mood regulation in the brain, there's genetic vulnerability, there's stressful life events like ACEs, medications can trigger mental health conditions, medical problems. But regardless of why it happens, it results in the same thing, which is an imbalance of neurotransmitters in the brain, which are absolutely essential to someone's level of functioning, how we perceive our world, how we go through life. And people are absolutely resilient, with some more resilient than others. But even the most resilient, we can only handle so much of this level of distress and the impairment in neurological functioning. So when someone has that presence of chemical imbalance, not only that, it can make it more difficult for someone to take the actions and take the steps needed for them to access the help needed or make the changes in their life that will help them get back to that point of mental functioning. So when someone has that level of distress in their brain, it can make them also more likely to turn to unhealthy coping mechanisms like self-harm or substance abuse, which then in turn increase their risk. Eventually, someone, because of the untreated or unchanged circumstances, they may eventually reach a point of hopelessness and helplessness. And the hopelessness is what is underlying a lot of suicidal action. So depending on the person, someone can be untreated for a length of time. With chronic health conditions, the symptoms persist. They can get harder and harder for someone to accomplish what they want to, which then could in turn lead to a tipping point event, because if someone can't get out of bed and go to work, eventually they're going to lose their job. If they don't have income, they may lose their housing. And all of these could serve as a tipping point for someone. And these continued feelings and the life events surrounding someone can reinforce those feelings of hopelessness and helplessness. And that's when someone may start to have suicidal thoughts. Though it is worth noting that just because someone is having suicidal thoughts does not mean they're actively suicidal. Some people use suicidal thoughts as a way of coping, kind of like a form of escapism, so they can mentally escape without taking physical action. But someone may eventually experience a tipping point. Like I said, one study said that 70% of people who take suicidal action, they have a tipping point event. And there are things that increase someone's risk of suicidal action, such as immediate access to lethal means and drug or alcohol use. Because suicidal crises are short-lived, if someone has immediate access to medication or a firearm, their risk of death increases. Yes, I'll make sure they've got a copy of the presentation. They'll probably send it out. It's specifically talking a little bit about firearms. Gun culture is a part of our culture in Tennessee, but we need to talk about it because 60% of firearm deaths are suicides, and firearms are responsible for half of suicides. Making firearms more difficult to access, especially during those times of suicidal crisis, can absolutely decrease someone's suicide risk. Drug and alcohol also factor into suicides. It's estimated that alcohol is involved in over a quarter of all suicides, and that a third use alcohol just prior to death, with a certain number of people having a positive blood alcohol content at the time of their death. But when someone has a previous suicide attempt, they're more likely to make future attempts. So anywhere along this, just because someone has attempted suicide doesn't mean we can't intervene. Everywhere upon this path, we can intervene. So what can we expect this school year? Well, we don't really know what to expect, but we should plan for it. We know that during a typical school year, mental health needs increase when the school year starts. In fact, there are a number of studies that point to this. A 2015 study found in the weeks that children were in school, visits to a psychiatric emergency department increased 118%, with hospitalization because of suicide ideation increasing 300% in school months. And unfortunately, even though kids are utilizing these crisis services, it actually doesn't result in a decrease in suicidal action. In fact, another study showed that suicide deaths among youth are actually much lower in the summer, and they were able to isolate this and show that the decline wasn't explained by weather, unemployment, or seasonal affective disorder, which can absolutely happen in the summer as well. This particular study found gender differences and that the suicide rates were 95% higher for boys during the school year, but only 33% higher for girls than the rates during the summer. And this would appear to suggest that boys have a much harder time adjusting to being back in school and having the change in routine. So when we view these statistics through the lens of the pandemic, I predict that we can expect to see an increase in rates in suicide as the year begins, making any prevention and intervention efforts really pivotal. So the intervention approach that I usually recommend is multifaceted. It's not just something we want to institute in times of crisis. In fact, we need to start making changes as soon as possible. First and foremost, the best intervention is by actively engaging in prevention efforts. One of the best things about the pandemic, and I was sharing with my family earlier, I think the only good thing about the pandemic is, as a rule, I think more people became more caring and understanding than they had before. And this is something that really needs to continue. And we need to start having more and more conversations about mental health. So start by modeling and sharing about your own emotions and challenges positively. Part of the efforts of prevention involve us getting over a lot of our own internal stigma when it comes to mental health, and starting to talk about these things in positive ways and being examples to the children and other people around us. Be open and honest about how you're feeling about your own emotions and feelings. And it helps other people feel like they're in a safe space to open up as well. Even if it means being vulnerable and self deprecating or even prideful, turning around. It doesn't have to be just negative emotions, saying like you're happy because of X, Y, or Z. If you struggle with your own mental health, please don't be afraid to disclose it. Definitely, if you're working with someone in a professional setting, I would say it's not necessarily appropriate to disclose all the, nooks and crannies of your own struggles. Maintain your professional boundaries, but it's okay to talk about what you've experienced and what you do to deal with it. Whether it be take a medication or talk to a therapist, or even if you do something for self-care, like taking a bubble bath or doing yoga. Children notice. A lot of learning that children do is not necessarily in the words they hear out loud, it's in the behaviors they see other people exhibiting. Have conversations with someone when nothing is wrong. Don't just ask a child questions when you think something is happening. Always be sure to use open-ended questions that are specific. So instead of asking, how was your day? Ask, what was your favorite part of the day? Or what was something that was difficult for you today? Whatever your role is with a child, you can create extra sort of projects or assignments like that will help you get an insight into someone's mental health or well-being. For example, I was at a health fair or a community event in Kingsport a number of weeks ago. And at our table, we made gratitude flowers, and we had to, the students, the kids that we worked with had to name 5 things that they're thankful for. And that can be just one thing that can give you an idea of what their mental health is looking like in the moment. Also, set healthy boundaries for yourself and help the children in your life set boundaries for themselves. Because if we're able to set and help set those boundaries early on, someone can understand what their own needs are and reinforce those needs. So even if a child is telling you like, no, I don't want you to do this, respect that feeling and make sure you don't do that action. Building self-care and coping strategies are also key during the pivotal and child and adolescent years, because the skills they build during this time, they're going to carry over through adulthood. Kids that have sleep issues as children, they're probably going to have sleep issues as an adult. So let's address them while our brain is more flexible and more resilient versus when our neural connections are a little more set in stone as an adult. So it starts with making sleep a priority, taking care of those basic self-care foundational things that someone needs to have, like having a good night's sleep, having a healthy diet, getting regular exercise. And obviously there are barriers to this. If a child is living in a setting where gunshots are going off every night, are they going to have trouble getting a good restful night of sleep? Absolutely. What can we do to overcome the barriers that are in place? For example, there are things you can do to improve the physical health of a family. A shout out to a district in Loudoun County, which is in East Tennessee. They created gardening baskets with seeds for fruits and vegetables for families, along with instructions on how to do everything. It's a simple thing, but when someone has access to fresh produce, it's going to decrease their food insecurity. And food insecurity, that is all mental health care. Creating consistency and routine is important. Kids, when they know what to expect, there is much less fear or anxiety. This is especially important for kids with anxiety disorder diagnoses. When we know what's going to happen, there is much less fear, and fear is poison to the brain. So we want to take away that fear as often as we can. Having rules that everyone follows, that's important as well. You can create this list of rules together. It can be a kid you work with one time, so they understand the expectations for them and they understand what expectations they can have of you. And creating a sense of belonging, that's really important too. No matter what role you have in a child's life, remind them that they're important and point out positive things about them. Compliment them for their unique attributes that aren't typically noticed. This may be complimenting them for their creativity, their thought process over a topic, or even small gesture that they do for someone else. I want you all to take a second to think about a time in your own life when someone gave you a compliment that really stuck with you and what that did for your own mental health. My moment is when a teacher wrote on a paper in high school that said it was college level writing. She didn't know, and probably still doesn't know, the difference that made in my own life, because I had always questioned my own academic abilities. And so that, even over 10 years later, I still think back to as something that was a bolster to my mental health. And so think about what you can do to give the children in your life, the people in your life, that bolster too. And also planning intentional time together, especially as a parent or in some sort of caregiving role. And I think this was also a benefit of the pandemic, is a lot more parents and caregivers were spending more and more time with their kids. So they noticed when they were struggling, and they were able to intervene or make changes in their home life that made a difference in a child's mental health. And you can use that intentional time together to learn new skills that foster resilience, which will be spoken about in next week's presentation. Because once we've created an environment where mental health is an accepted part of the conversation, and we have filled our toolkit with healthy self-care and coping strategies, it's time to turn to that resilience. Someone's mental health is like a foundation. We're all going to have cracks in it, right? Some people are born with cracks in that foundation because of their genetic predisposition, but trauma happens in most people's lives. But when we build our resilience and build these skills, it's like adding those extra beams and supports. There's still going to be cracks, but it means our foundation isn't going to tumble down. So we can build those skills like having healthy relationships, having a positive view of self, helping children manage strong feelings and impulses, because they're going to have them, but learning how to channel those in healthy and positive ways. People who feel in control of their life, they're more likely to be resilient. And if someone is able to find positive meaning in life despite traumatic events, that improves someone's resilience as well. And a lot of these skills we can't necessarily build for kids, but we can teach them the skills they need to learn to practice them in their own life. And we can learn these skills ourselves and model them as healthy ways of addressing our emotions. Another thing we can do to improve the mental health of our kids is by continuing to educate ourselves on how to recognize these signs of mental distress and suicidal ideation. On the left side of the screen, I've listed some warning signs of suicidality. Any of these would indicate you need to take suicide intervention, likely immediately. I also highly recommend taking additional trainings on mental health and suicide. Most local mental health providers or mental health advocacy organizations are more than happy to speak with your workplace, your clients about mental health. There are also evidence-based programs such as mental health first aid, and for suicide intervention, I highly, highly recommend, if you haven't already, taking a QPR class, or my personal favorite is ASSIST. In fact, I think everyone who works in the helping field needs to take an ASSIST class at some point. Shout out to the Tennessee Suicide Prevention Network, who offers both QPR and ASSIST trainings. But if we believe someone is experiencing a mental health issue or is suicidal, we always start at the same place, with a conversation, trying to get more information. Without prying, just starting the conversation and letting the person use you as a sounding board for whatever they're experiencing. Don't blame or judge someone for what they're experiencing. Again, don't try to throw logic at it and try to explain like, oh, you shouldn't be feeling this way, or what you're experiencing isn't that bad. Respect what someone is feeling. Don't invalidate their feelings. When someone is told that what they're feeling doesn't make any sense or it's not that bad, what it does is it reinforces those feelings that something is wrong with me. And then they end up shutting off. And thank you, Serena, for sharing that. It can make them feel alone or ignored. And as someone who works with children on a regular basis, I can tell you children who are struggling are reaching out. They're trying to reach out to the best of their ability. And what they worry about is being rejected or being not taken seriously. So once you've reached the crux of the issue, you've given a person space to share, we have to help them move forward into a healthier space. With any process, ideally, the child would be involved. No change can really happen without a willing participant. Even with children and adolescents, when we can make that decision for them, outcomes are much better when they're a part of the process. I encourage people, when we're thinking about mental health, to use every tool in their toolkit, because mental health and mental health conditions exist on a spectrum, so everyone responds to things differently. People have to figure out what works best for them, but also not lose hope during the process. Because for some people, therapy won't be effective. For some people, medication won't be effective. So doing as much as we can all at the same time will increase our chance of successful overcoming of the signs of mental distress. Some people with mild symptoms may be able to manage them through changing their coping and self-care routine. But when self-care and coping don't relieve those symptoms, then steps need to be taken to get the child professional help. So connecting them with care if they are, especially if they're self-harming or suicidal, and your role is important. Parents and guardians need to be informed, specifically making sure children don't have access to lethal means, securing the home. If you're unsure of how acute the mental health need, never be afraid to call mobile crisis. There are some, at least for the East region through McNabb Center, I've been assured that if you have any questions at all, don't ever be afraid to call and to see if mobile crisis is the appropriate next step. If you don't have any concerns about suicide or self-harm, generally the next step is to interface with the child's pediatrician or medical professional, because there are physical health conditions that can mimic the symptoms of mental health conditions. And just to be frank, treatment for physical health conditions is generally a lot more straightforward than mental health conditions. So that should always be assessed before pursuing any other sort of treatment options, such as seeing a licensed clinician or pursuing medication. Unfortunately, even when we take all those steps we need to get someone help, there are a number of complicating factors. First, someone's willingness to enter treatment. For good reasons, it is harder for someone to get committed than it used to be. Someone usually has to be at current risk to themselves or others. Some people end up in jail instead of accessing treatment. And so the criminal justice system has ended up being a place for mental health treatment. And simply, some people just don't want to get better. This could be because of their symptoms. They're preventing them from seeing sort of that hopeful place, especially with diagnoses like psychosis or bipolar disorder. It can be harder for someone to self-seek services. For some communities, simply we don't have easy access to resources. It's not uncommon for someone to wait weeks for an appointment, even in larger cities with more clinicians. And like I said before, more and more providers aren't billing through insurance anymore, which really puts the cost of care out of range for most people. Difficulty accessing treatment is especially difficult for those in rural communities. And in Tennessee, 93% of land is rural, with 70 of our 95 counties having at least half of their residents living in rural areas. And we know that a majority of rural mental health providers say they can't meet the needs of their communities. And so if we can't meet these needs before a crisis, then eventually we could deteriorate to that point of crisis. And in general, there's just a workforce shortage in the behavioral health care field right now. There are fewer people taking appointments, which means fewer people are being able to be seen. And there are efforts to increase the behavioral health workforce in Tennessee, but it's still not where it needs to be. And lastly, mental health care is just not achieved parity to other medical services. Mental health reimbursement is typically done at lower rates, which is why so many private practice clinicians end up not going through insurance. It's just not worth the headache. It's just easier to take that money out of pocket because they know they can get it, because we have already established more people need mental health care. And when the cost to accessing services are high and someone's budget is already stretched thin, if someone can't afford their groceries, you can guarantee they are not going to take that step to see their therapist. Because hopelessness is a place where suicidality originates. Despite individual and societal circumstances, it's essential that we have to maintain our own hope and build the hope as much in others as much as possible. So it not only starts with leading by example, having healthy conversations about mental health, setting our own boundaries to improve our mental health, saying no to workforce projects when we can, maintaining that work-life balance, and maintaining those boundaries in our social life as well. Most people with mental health conditions do not become suicidal, but that's no reason not to intervene. Everyone is worthy of having a happy and fulfilling life. So it's important to advocate for services for yourself, for the services for the people that you work with. And that not only includes on sort of an individual community level, but statewide as well. If mental health is something that you're passionate about, get in the ears of your legislators and know that mental health is an issue. And advocate for system changes that make mental health care more accessible. Anyone that works with children can tell you the number one thing they are concerned about is the mental health needs of their kiddos. But when we are dealing with those systemic issues like food insecurity and those other things, mental health care ends up falling down on that list in terms of the needs that we prioritize. And so there's a lot of work that we need to do, but when we start having those one-on-one conversations, that becomes bigger, and it will become bigger. And a lot of change has happened regarding our conversations with mental health, but there's still more change that needs to happen. And I agree, Danita, that it is definitely hard to get children's help, especially due to the pandemic, which is why it's important to start with those foundational things, because we don't know how easily we'll be able to access those services. So throwing everything we have at mental health challenges is sometimes all we can do, especially when we can't access actual clinical services. In case you are interested in learning and looking more into suicidality and its connection to mental health, I've included my resources that I used to put together this presentation in my last 2 slides. I definitely encourage you to do more research into suicidality. There's only so much I can cover in an hour and a half, but I would like to finish up by just extending my deepest thanks for the invitation to speak on this topic today, and I would be happy to answer any questions anyone has at this time.
Thank you so much, Caitlin. Let's give people just another opportunity to add some questions and comments in the chat box. Thank you all to everyone. You got a lot of accolades, Caitlin, and I agree with that. Great information. I learned a lot today as well, so thank you.
And I will say, I really, truly encourage people to educate themselves more. I know where I work, the Mental Health Association of East Tennessee, we're more than willing to do workplace or client trainings, and I know a number of organizations are also willing to do the same. We may not be able to address the systemic issues, but like I said, I think a lot of change, it happens at the personal, at the individual level, and then it can grow from there.
Yes, thank you. Thank you. We have a few questions about the PowerPoint, so I will be sending a follow-up email in the next few days, and that will include a PDF version of this PowerPoint, so we all can have access to that as well. Thank you. All right, well, I don't see any questions then, Caitlin. It looks like you did a fantastic job as always, and you have some some new fans. So glad to have you all on. If you all do have any follow-up questions, things that you're thinking of after the presentation today, you can just send those to me in an email, and I'll make sure that we get those to Caitlin and get an answer back to you. But I do want to say thank you to everyone who participated in our training today. And thank you again to Caitlin for taking the time out of her day to share this information with everyone. I hope y'all have a great rest of your day. And I hope you do sign up for our next session for our session next week, the same time and on Tuesday. Thank you all again. Bye-bye.